at the end, but if you think of something as we're going along, please do put your questions in the chat and we will keep them there and come back to them at the end. But what we're hoping to do in this webinar today is to give you an update on what's happening in the pressure ulcer work stream. I'm going to start chatting whilst Francis tries to share the slides for us, or get me able to share the slides, but I'll just give you a little bit of the background information. As soon as we get the slides, we will carry on. So we've got quite a lot of activity actually happening in the pressure ulcer work stream. It sometimes feels like we're really focused on one thing, but there's a lot of different activities. So things that I'm going to touch on today will include the pressure ulcer sequence number 12, the pressure ulcer surveillance system, and I'll just start sharing if I can, the e-modules that we have, patient and carer resources, the Stop Pressure Day activity for 2023, the best practice bundle and the underpinnings to that, the clinical recommendations and clinical pathway, the quality improvement programme that we're engaging in, and a new thing called Pressure Ulcers Matter. And I'm just clicked onto slide share, so I'm hoping my slides will come onto slide share for you. I'm going to start with the pressure ulcer sequence, not because it is the most important thing, but I think it is for some of you the most pressing thing. And I know lots of you are starting to have conversations with your sequence teams around what's happening. And the really different thing for this year is the sequence change from last year. So we had a pressure ulcer risk assessment sequence in 2022-2023. This year we've extended it from community to cover acute organisations, and we've also had an increase in the target. And the target this year is to achieve between 70 and 85% agreement with the sequence. And for those of you who are thinking, how come it's been increased? There is a good reason for that. We had really good achievement of the target that we set last year from community. And in consideration of taking it into acute, we looked at the data that we have from the National Pressure Ulcer audit that we did in 2018-2019 to look at what the achievement was for risk assessment in there. So we haven't just guessed at what the sequence target should be, we've set it at what we think is realistic for you to achieve. As well as the actual sequence document itself, you will find that there are documents on the National Wound Care Strategy webpage to help you with the sequence. We've already had lots of questions and comments coming in from organisations and from tissue viability nurses who are involved. So to help, we have done two documents. We have prepared a frequently asked questions document, which was loaded up last week. There is a query outstanding. I've had a query from one particular organisation about if the sequence includes maternity. As far as I'm concerned, yes, it does, because the denominator is that it's all adult patients. But we've taken this to the sequence specification team and we will confirm that, and we will add it onto the sequence FAQs once we have that information. Within that document, there are links to the actual sequence specification and guidance, which tell you what you need to collect. But to make it easy for you, we've put together a sequence data collection tool for the audit. So you can see that there are here all the different criteria that are within the sequence. There's a list of how you gather them. And then at the bottom, there is, have you achieved every element of that particular part? And in order to achieve your sequence criteria, you have to achieve all of those 4 measures. So you can't achieve 80% in one and 100% in another in that count. It has to be 100% across the board. I'm going to hand over to Heidi now, who's going to talk to you about the surveillance system. As if Heidi just tells me if you...
Okay, I'll do a Chris Whitty. Next slide, please. Yeah. So thanks, Jackie. Thanks, everybody, for having me here today. Just want to give you an update on where we're at with the National Pressure Ulcer surveillance that we've been looking at. Largely, the ask was around finding a replacement for safety thermometer, which gave us a national view of what was going on with pressure ulcers, and that was stopped in February 2020. So we've been doing a piece of work to see what we can put in its place. So we want to follow some key principles now as we move forward with data capture nationally. And there's 3 principles here, but I want to draw your eye to the top one, which says data capture must be secondary to operational practice. So if you think about safety thermometer, we were taking clinicians out of practice for 1 day a month to wander around wards and in the community, looking for patients, checking their skin, seeing if they got a pressure ulcer. What we want to do now is identify where we've got that information already recorded in clinical records and be able to pull that information out so that clinicians are recording that information as they deliver their clinical care, and then we can get the data out the other end without there being another layer of work for clinicians to do. We also need to be mindful that we have to understand what the clarity of purpose is for our data capture and what the level of granularity is. So what I'm showing you today in terms of granularity is a national view. So it's bigger data, if you like. Those of you that are working in hospitals, for instance, might want to know more finite data right down to ward level or body site and things like that, which we won't be able to do at the moment. So yeah, next slide, please, Jackie. So what the changes largely are is that we'll be using patients' clinical records to capture our data, and then we'll be able to view that in the model health system. Rather than having individual views that we've got, we know that there are trusts that have got different ways of viewing their data, different systems supporting that. But if we've got one national view, came out of the Carter review, that was a suggestion that we continued to use the model hospital, and that's been expanded into the model health system now. So next slide. We haven't got a launch date because it's already there. So for those of you that are working in the acute care in England, you can already see pressure ulcer information in your model hospital system. That was launched not long after we started the pilots of this back in September 2021, and we've since adopted some fast follower sites as from April 2022. So we've been working with these organisations to help them. Well, first of all, they helped us greatly understand what it was we needed in order to get the data out of the clinical records and into model hospital. But also we've been able to learn with them about what we need clinicians and people from the clinical coding teams to be doing in order to make that data as accurate as possible. Next slide, please. Just to give you a little overview of what model health is, because sometimes I might say model health, sometimes I might say model hospital, might confuse. I just need to point out that the only logo that's official here is the model health system logo, and the model hospital one. The others I've kind of made up just to make a point, but model health is an umbrella term and it's got 4 systems within it at the moment. Model hospital for those of you working in acute care, model ambulance, model community health, so I work in a community organisation, so that's what I see, and model mental health. Next slide, please, Jackie. So there's a lot of clicks here, Jackie, so we'll just, you might as well just click to the end. So we just want to show you what happens now when a patient comes into hospital. So when a patient comes in, they are admitted into your care, and from point of admission, that is the beginning of a spell. And a spell is the time that they're admitted to the time they're discharged. They can have 1 or 2 or 3 or more consultant episodes within that spell, but what we're talking about in terms of time spells for model hospital is spells. So time they're admitted to the time they're discharged. You're recording your care, as are many other clinicians, whilst you're seeing these people and caring for them. And you might be doing that electronically, you might be using paper records, you might have a mix of both. When the patient's discharged, their clinical records go to the coding team, and the coding team will sift through all of the clinical information, looking for diagnostic codes and codes related to treatments and procedures. And they will pull this information out and they will turn that into a code, and they use an official list of diagnostic codes for treatments and investigations. They have 2 lists, one for each, and that is what they use. They will not stray from that. And they will turn a diagnosis of a pressure ulcer, for instance, into a code. And then that code goes into something called SAS, which is Secondary Uses Service. And then that is then translated annually into HES, which is your hospital episode statistics. And then we can start to see data around admission data. So it tells us what patients have been admitted for, what care they've had. It can tell us something around length of stay and things like that. And largely that is all about payment by results. So that is how, at the end of the day, an acute organisation can get paid for the care that they've delivered. But what was interesting to us was that was an existing source of data that was already happening from clinical records and coming out the other end, which meant clinicians weren't having to do anything different in order to get the data out. So unlike if you think about our clinical incident reporting that most of us are probably using for our pressure ulcer data at the moment, we're recording pressure ulcers in the clinical records because that's where we should be recording them. That's the official record, that's the legal record of care that that patient has had, and that's the right place to be recording it. We also then record incidents, and we call a pressure ulcer in England a clinical incident, and we're capturing information about that as well, but that's more about learning and about what's been going on in somebody's care or within an organisation. If you look at the new PSERV recommendations, you might be thinking about that in a bigger way rather than just looking at individual patients. So we want to move away from using that as our data and using clinical records as our data source. Thanks, Jackie. So if you're working in an acute organisation at the moment in England, then what might this mean for you? So it might mean that if you're working as a tissue viability nurse or in quality teams or patient safety teams, that you want to be looking at how clinical records are capturing pressure ulcer information now. What is the accuracy of information that's put in there? What's the level of knowledge and skills around people's ability to categorise, for instance? Is it clear where this information can be found? Because our clinical coding teams need to know where to look for it in order to find it. Also familiarising yourself with the hospital system and how things look. And I'll just give you a very quick glance at that during my slides here. Starting to think about this as an organisation and how you want to be using this data and improving it. I think the first year, possibly longer, when you start looking at model hospital will be about your data quality improvement. So improving the quality of what's in the clinical records so that you can improve the quality of the data that you get out. All the clinical coding teams know where they look in there when they're coding, and some of them might only be coding from medical records, which often doesn't have very good information about pressure ulcers. So it might be that they need signposting to somewhere else to look for pressure ulcer information. They use, as I've said, official coding lists, so ICD-10 for diagnostic codes, and the code for a pressure ulcer is L89, and that is, and they also have an additional point number code that's linked to each of the categories. There is also a code for acquired in our care, so Y95, which is a nosocomial code, and they can assign that to lots of other diagnostic codes. They commonly use it for pneumonia, for instance, but they will also assign it to a pressure ulcer if it's clearly documented in the clinical records that that pressure ulcer was acquired in hospital. They cannot make assumptions of diagnosis. So if somebody's written query pressure ulcer and they've then never confirmed it, they will not code that as a pressure ulcer. It has to be definitively stated that it's a pressure ulcer. Now, of course, we're all really interested in how many were acquired in our care and how many were present on admission. But at the moment, there isn't a code that clinical coders use in secondary care for present on admission. That sits in another coding data set. And there is a piece of work going on at the moment to look at how we can use that around pressure ulcers and other things, but that's out of our scope at the moment. Thanks, Jackie. So from the pilots and the fast followers, we've learnt that data looks very different when you look at it in model hospital at the moment. We know it's growing and there's definitely some data quality improvement to be done within there. When a coder is coding the clinical records and they have strict guidance about what they do, they will only code the highest category that is in there. So if somebody's got a category 2 and a category 4 recorded in their clinical records, they will assign a code to the category 4, but not the category 2. So for each patient spell that you see in model hospital, there should only be one pressure ulcer coded against that spell. Their codes have codes for categories 1, 2, 3, 4 and unspecified. So if we've written an unstageable pressure ulcer, or we haven't put a code, a category next to the pressure ulcer, or we've called it a mucosal pressure ulcer, they're likely to code those as unspecified. So there'll probably be a large number of pressure ulcers coded as unspecified. Model hospital does include category 1, which of course you probably aren't including now when your DATIX and your clinical incident reporting. And then for the coders, they need to know where to look in the clinical records to find these codes. They need also to know if one pressure ulcer has been categorised as a 2, then a 3, and one's been overridden by the other, which one do they use? So having conversations with them about that is quite important. Next slide, please, Jackie. So have a think about which clinical records are coders using already. If you want to start looking at model hospital and how your pressure ulcer information can be improved. Are they coding pressure ulcers already? I'm sure they probably are. They're very knowledgeable. We learned a lot from talking to them. And if so, where do they get that information from? And are they using Y95? And what do they need from the clinical records to be able to assign Y95 to a pressure ulcer code? Next slide, please, Jackie. I can see you're multitasking, answering questions and doing the slides. This is just to give you the web address. If you haven't already registered for Model Health, then you can all do so if you're working in an NHS organisation with your NHS email. So that's the website to go to register. Next slide. So just to give you a view of what it will look like in Model Hospital, slightly different for community, and Model Mental Health and ambulance. Your first page has opportunities for improvement at the top. Sorry, Jackie, just go back. And then you can see quite early, high up, quality of care. And that's where at the moment we're putting wound related data into quality of care. When you click on that tile, as they're called, it will then take you through to the next page, please, Jackie, which takes you through to another page where you'll see wound care and pressure ulcers. And then you can click on pressure ulcers and it brings you through to this. So this is how the data looks. This is almost all of it. There's a section missing at the bottom just because of the screenshot for age breakdown of pressure ulcer cases as well. So you can see the number of spells that had a pressure ulcer diagnosis present as a proportion of all spells. So out of all of those spells that have been during the reporting period, how many of those spells had a pressure ulcer? Now, it's not that common for patients to come in and out and in and back out again within the same spell, but we know there will be an element of that. So there will be, we think, very small amount of double reporting on that. You can then see pressure ulcers by category, and then you can also see them as if they were acquired in hospital as well. And you can see that this organisation that I've used is using the Y95 code because they've got a lot of percentages around the acquired in hospital. Some of you might look at that and they might be zeros all the way down. Now, if that is because none of your patients have acquired a pressure ulcer in your care, share what you're doing with the rest of us because we'll all want to know. But chances are it's about the coding, and it's about the fact that clinical coders can't code acquired in hospital because they need those words written next to the pressure ulcer when it's recorded in some way. Also on this page, you can see I've pointed there with an arrow to a little blue arrow there. That will give you, you can see these things as a percentage, or you can see them as a count. So you can see them as numbers as well. And then on the right, you'll notice these little bars with different colours in. When you click on those, that'll take you through to what the charts look like. So I think, Jackie, my next slide is a chart. Yeah, so there's 3 views that you can see when you're looking at the spells with a pressure ulcer view. And this first one is called the variation chart. Now, you as a provider, you will be the black line. All the rest of these lines are other organisations across the country. So some of you might immediately start thinking, oh, I want to look at those green ones down there because they're obviously doing really well. I would say no, they're organisations that are very small children's hospitals, small cancer hospitals, for instance, organisations like that. And then at the other end, we've been working with some of these organisations who are at the red end. And actually what it is about them is that they're doing good data capture and good coding. So I think at the moment, we can't trust this to use it as a benchmarking tool. We have to see this as our way of seeing that our data quality is improving. So that's the one view that you'll get. The second view, when you click to trend line, is a wavy line. Now in this one, you're the blue line, and you can see that you've got grey and black lines, which are linked to whether you're peers or the national median. So you can actually see where you sit nationally. But again, because we know that people aren't capturing data and recording it and coding it well and pulling it out properly, we can't trust this yet as a benchmarking tool. What I do like is, though, you can see a nice peak there at March 2020, which was common both to this organisation and nationally, which I think we know what was happening then that might have caused such a spike. And then the final chart that you can now see is an SPC. Some of you might already be very familiar with SPC charts. If you're not, I've put a link there to making data count. It's well worth learning about SPC charts and understanding them. So this is all for the acute hospitals. We are looking at how we can get something similar for community providers as well. We know that community providers largely are using electronic records. What we're trying to understand is how we can pull the pressure ulcer data out into something called CSDS, which is the Community Services data set, which is where data gets pulled nationally and sort of held, and how we can get it into there so that we can get it out of there, that we understand what it is, and how we can then get it into model health. So that's a piece of work that we're doing at the moment. So if you're working for a community provider, we haven't got that yet, but we are looking at it. So I think, Jackie, that's the end of my little bit. Yeah, thank you.
Thanks, Heidi. And I can see there'll be lots of questions at the end. I've tried to answer some as we're going through, but I'm sure we can pick up on them and go through them in a little bit more detail. So the next thing that I want to talk about are the e-learning for health e-modules that we have, and most of you will be familiar with the fact that we have a tier 1 pressure ulcer module, and I know some organisations have made that mandatory within their mandatory learning, and we're planning to develop 2 further pressure ulcer related modules. The first one will be on Purpose T, because Purpose T is the tool we will be recommending from here forward in England, and a second one on assessing dark skin tone, because we know this is something many organisations are starting to develop themselves, and we'd rather have a central resource. We're also working with an organisation called the Patient Experience Network. This is a charitable organisation that brings together patients and carers to have a voice in all types of different health education. And they're working generically with us at National Wound Care Strategy to develop a range of resources that they are co-producing. The first one that they're doing around pressure ulcers is on pressure ulcer prevention, and you can see just in the corner of the screen there, this is the first draft of this. So this is not really ready for sharing yet, but just to give you an idea of the kind of thing that the patients are saying is important to them and how they think it's important to involve their own voice. So you can see there are patient quotes involved in that. Next thing is Stop the Pressure Day. Now, I know Stop the Pressure Day seems a long time away because it's November, as always, but actually there's an awful lot of work that goes into putting the Stop the Pressure Day activities together. And most of you will be familiar with the fact that last year we worked with the Society of Tissue Viability and Wound UK and the Journal of Wound Care, or the Mark Allen Group, and we had some really great resources and some amazing feedback, and the hits on our social media were far in advance of anything we've ever had before. So we're keeping that formula. This year, we've already decided the theme. The theme is going to be around Every Contact Counts. And we chose this theme because we always try to think about something that's generic. So whether you work in hospital or community or mental health or midwifery or paediatrics, whatever it might be, you can find something in here that works for you. And it may be that you know your organisation has something that you particularly want to focus on, whether that's use of equipment or it's heel offloading or risk assessment. If it's generic, you can tailor this to you. And what we like about this Every Contact Counts is that it's kind of a dual message. It can be about every contact counts as we mean it, that every time we see a patient, we should be doing something. And that involves all our therapy colleagues, our medical colleagues, our general practitioner colleagues. All of that is important. But it's also about what the patient is in contact with. So are they using a cast on their leg? Have they got a device in contact with them? What about their bed or their cushion? All those things they're in contact with make a difference. It can be, for some people, about contact with their local healthcare leaders or about using social media and how we bring that in. So we think that's really, really important. So we are doing as we did before, doing this big collaboration and really importantly, doing it as a Four Nations approach. And that Four Nations approach is also why it's important that we have a broad theme, because things are slightly different in Northern Ireland, Wales and Scotland than they are in England. And we don't want to be England centric. We want to make this for the whole of the UK. So we are currently meeting every 3 weeks. And the final elements haven't yet been agreed, but we are going to pick up on the things that worked really well last time. So lots of you liked the short videos that we had, you liked the social media campaigns. I think there were a lot of people got engaged in the quizzes. We're still seeing people take the Purpose T quick quiz. I know Society of Tissue Viability team told me that that's still being used very regularly. The word search was a challenge for some people. I can't believe people solved it in 24 seconds. There will be some more digital assets that we will start to put onto the websites, and we will have a range of more films, not necessarily the patient focused ones we did last year. We haven't quite decided what that will be yet. So then the main piece of work that we're involved in are the next things that I'm going to talk to you about. And we are putting together 3 items, but they are all so interrelated, it's difficult to talk to them without talking about all of them. So we will be developing a best practice bundle, which within that bundle or supporting that bundle, there is a clinical care pathway and a set of clinical recommendations. So the best practice bundle is really about giving the detailed information for providers and commissioners of care about what to do for those at risk or with pressure ulcers and how they can reduce the time to healing. So it's not just about prevention, it's also about reducing the time to healing, because the only way we will reduce the burden of pressure ulcers, not just on the health service, but on the patient, is by preventing them. But if unfortunately do occur, by getting them healed as quickly as we can. So the bundle gathers together these resources to support implementation in organisations of the best available evidence. And how this differs from anything we've had before is the weight that it's given. This will be an NHS England document, so it will be referred to by organisations like CQC when they're doing their inspections. In the course of going through some of the drafts of this work, and particularly the drafts of the recommendations and the clinical pathway, it's been drawn to our attention that in the return to practice and international nursing modules, the tool that's recommended, or that the tool that the nurses are assessed on in their OSCE, is the Braden tool. So we've had conversations with NMC just last week to look at how we can change this. Now, we don't want to say that they can only assess on Purpose T, because you may have return to practice nurses and international nurses coming into your organisation now, and you might be using Waterloo or Braden or something completely different. But what we do want to do is to make sure that the NMC are not asking people to be tested on something that when we are making a different recommendation. So we're looking at how we can make that a bit more generic about how they assess on understanding risk assessment and the role of risk assessment tools, but working towards including Purpose T in that. So the bundle will bring together those elements of best practice that we have good evidence for. So it will pull from things like the International Pressure Ulcer Guidelines and the NICE guidelines, where we know we can significantly reduce the risk, but also where we can improve patient experience. And I think it's important that we consider the role of the patient and that patient experience, because sometimes we are challenged by the fact that the patient does not want to do what we want them to do. And if they don't want to use a piece of equipment, then that equipment is not efficacious. We also want to think about the use of the NHS resources and costs. We are all very aware of the situation we're in at the minute, and we want to make the best of the resources that we have. So the clinical recommendations will underpin this, and we are working very collaboratively with this to make sure that we are looking at what both the patient safety team and the nursing directorate from NHS England want as well, so you're not getting conflicting messages. From the incident reporting system that Heidi mentioned, and it's important to say that however much we rely on the incident reporting system, we know it doesn't pick up all the pressure ulcers. There's really good data to show that we find many more pressure ulcers when we actually check in other places. But pressure ulcers are definitely in the top 10 harms. And when we investigate them, so when you do root cause analysis, the most common thing is that there's variation from evidence-based practice. And that's difficult to challenge when we don't have a standard pathway in England for what people should be following. So what we have in each organisation is that organisation's interpretation of the international and the national guidelines. So what we want to do is reduce the burden on people in making their own guidance and start to pull it together in a standardised way. So the clinical pathway will define what good looks like and give you a process to follow. And as I said, it's based on NICE guidance and the NICE standards and the international guidelines. The most important element of this is that it's not just about hospital or community care. It's best practice for care in all health and care settings. So on our reference group, we do have representation from the care setting, from nursing homes, and we're also looking for representation from general practice. It's suitable for people with physical and mental health care needs, and it seeks to inform and support care delivered by all health and care professionals who care for patients at risk of pressure ulcers. So in the pathway, there are 5 sections, and the first one is identification of someone at risk of pressure ulcers. And the second one is risk assessment. And you might think that they'll sound the same, and it's a bit confusing. But actually, the first one is about recognising the fact that there are many patients who come to our care with an existing pressure ulcer. And this is part of a big piece of work we're doing. I've already mentioned the PEN work, but trying to raise awareness of the general public about risk factors and getting them to come to us. So there will be that early, before healthcare bit about identification of risk, and then the formal risk assessment and screening. Ongoing care, review of healing, and the care following healing. Now, before I click the slide to show you what the pathway looked like, I just want to put a disclaimer up. This shows my limits of PowerPoint. Before this is published, it will go to a proper graphic designer. So if any of you are looking at it and thinking, oh my goodness, that's kind of really hard to follow, the colours are horrendous, I can't work out where the arrows go, please don't worry, it will look much better. And it is really straightforward, and it's nothing that you aren't already doing. So the bit on the left as you look at it is that outside hospital bit. What can we do to get the public aware of what they can do and when they should escalate to us? Then we've got risk assessment and diagnosis built around purpose T and that red, amber, green model. We've got preventative care based on the ASKIN bundle. We've got wound care based on the common wound assessment minimum data set and the good guidance we've got on management. And we've got that important red bit about escalation of interventions if there's deterioration in the skin or the wound. And this is kind of getting people to understand, if that you've been delivering preventative care and your patient develops a pressure ulcer, you can't keep delivering the same prevention. You need to escalate that. You need to step it up a little bit. It's followed by the formal review, and this is about making sure that we are looking at if our pressure ulcers are healing and not deteriorating, and how we escalate that, and also which patients we should be thinking about should be going for surgery. And there's a big piece of research being done by the team in Bristol and Manchester called SIPS study, and that will be feeding into this. And then it all loops back round. So this is just one screenshot from the recommendations. I don't plan to go through them all for you, but just to give you an idea of what it looks like. So there are a series of statements that tell you what you should do. And we've tried to make them quite instructional, that this is what you do, so that if somebody picks it up, they know exactly what they should be doing. And it includes very clearly not just the doing, but the documenting. And as Heidi mentioned when she was talking about the model health system, it says document in the care record, because the care record is the place we will find that further information. Then the final piece of work that we're involved in as generically as the pressure ulcer workstream is the putting together of a new patient-facing campaign and website. You are probably thinking that says Legs Matter. Yes, I know it says Legs Matter. What we're aiming to do is develop something really like Legs Matter, because from what we've seen of this is it works incredibly well. So we are not ashamed at all that we're just going to steal their idea and try and do something very similar. So it will be a patient-facing resource, it will be co-produced, and we will have a series of collaborating organisations involved with us. So at the minute, we've got the Spinal Injuries Association, we've got SHINE, who are the Spina Bifida and Hydrocephalus network, and we've got engagement from the Limbless Association, who I was only aware of very recently, but they are very keen to be involved with us and engaged in the work that we're doing. So within that resource, much like within Legs Matter, we will see a series of resources. So I mentioned the pen information leaflet, but that's our first one. That will be one of the things that goes up on the website. So there'll be leaflets generically around prevention and also about specific aspects of care. There'll be a kind of hints and tips session, guidance on how to speak to your healthcare professional and where to find help and guidance. This is really kind of draft. We haven't got an outline or a structure for what this will be yet, but that's what we're anticipating will be in there. We don't intend to create all the resources new. We will look at where there are existing resources. So we know there are some really good YouTube videos already. We made a whole series of digital resources last year as part of Stop the Pressure campaign, and we will of course be pulling those through. What we won't do is put every single resource in there. So everything that will be within Pressure Ulcers Matter will be something that has been verified by the team and that we are comfortable that it is suitable for patients and their families to review. And then before I finished, I wanted to mention the fact that the European Pressure Ulcer Advisory Panel will be in England in 2023. So if you haven't yet seen it, you will see that the Pressure Ulcer Advisory Panel will be in Leeds in September. And that there are a series of dates there at the bottom that you might want to make a note of. So if you are doing a piece of work around pressure ulcer prevention and you think it's worth sharing, whether that's you've been working with your coders and you've improved your data capture, or whether you've done a really big piece of quality improvement work or a small piece of quality improvement work that's really made a difference, you have, I think it's about 7 weeks to submit your abstract. Early registration starts from the 30th of June, and as I said, the conference itself is in September. There's a huge range of topics that are going to be there, and we're really proud to say that we will have a symposium that National Wound Care Strategy will be putting a session into, similar to these updates we're talking about today, but obviously we'll be 6 months on from then. We will also have a session talking about what we're doing for Stop the Pressure Day, and we will be working with Society of Tissue Viability on that. So it's a 3 full day meeting, so it's much easier to get to this year than usual. There will be a lot of hands-on workshops, lots of networking activities, social events. There's going to be, it's going to be held in the Royal Armouries. There's going to be an enactment, I believe. There's going to be a big exhibition. And because it's in England this year, I think it's much easier for people to get to. So that's my final slide. Here's the contact details. If there's anything you want to pick up with and follow up on, I will now stop sharing. And I can see Heidi's also been answering questions whilst I've been talking. Let's have a see if there's anything that anybody wants to pick up. If there's anything if you do want to ask a question, please do feel free to put your hand up, and we will do what we can. I'm just quickly whipping through to see if there's anything. Heidi, is there anything you've picked up that you want to start with a question?
So I think if we start with Krista, because I think we've answered everybody before that. Krista Dyson was asking, with Stop the Pressure 23 campaign, will we be working with charities as well?
We will be working with anybody, Krista. You know, we are really happy to engage with anybody via social media or as part of the team itself. And if you do work with a charity and you're interested in being involved, please do let us know.
And then a couple of big questions. So what about suspected DTI and unstageable damage? Where are they in the pathway?
A very good and not unsurprising question. Within the coding system that you heard Heidi present, you'll remember she said there are only codes for categories 1 to 4 and for unspecified. So we are taking a decision at the moment that what we are going to do is, with unstageable, if you recall, the definition quite clearly says it's full thickness skin damage. And so as a minimum, it is a category 3. We've looked at some quite big data sets to look at the number of unstageables that convert to category 3 and category 4. And we know that very few of them do convert to category 4. We're not saying none of them do, but we're saying a small number. So for the purposes of coding, we're asking people to record in their notes that this is an unstageable, a minimum category 3. That will then get coded as a category 3. And if that then reveals you debride it and something evolves and you can see it's a category 4, you can then record it as revealed to be a category 4. So that's not a deterioration, that's just an evolvement of what it is. And because a 4 is worse than a 3, coders will code it as a 4. with the DTI, the suspected DTI, we have listened to the feedback from the original document we did when we did definition and measurement, and we know that putting that you must follow up all the DTIs caused a significant amount of work for a lot of people. So what we've said in terms of DTI is that not to record it as a pressure ulcer. And at the minute, if you record it as a DTI, the coding team wouldn't pick that up anyway, because it doesn't say pressure ulcer in those words. So we're asking that you observe it for 72 hours, and then once it evolves or resolves, you code it as what it is. So it might evolve to an unstageable, so you're going to code it as unstageable minimum category 3. And if it resolves and it goes away, then we're not recording anything that isn't there. So we're trying to reduce the workload in terms of what we follow up. Now, somebody's got the hand up and I can't work out who it is. People, let me look. Oh.
There's another question about consultation on the work that you've just shown, the recommendations.
Yeah, so we will, as with all national wound care strategy things, take these documents out for consultation. We had hoped to put the clinical pathway and recommendations out a couple of weeks ago, but we were then asked to start work on the care bundle, and it felt better that we kind of aligned the two before we sent one out for consultation. So we think we now have got agreement on the direction that the care bundle will take. So we will hopefully be sending out the clinical recommendations and the clinical pathway for as soon as we can. And we will make sure that we notify people in the usual ways by social media and by the regional groups.
Another question about why isn't data being taken from reporting and from clinical notes? As a TVN, I take all PUs from reporting onto my caseload and verify the reporting category following assessment. Would this not be more accurate?
Heidi, do you want to pick that up in terms of there's 2 points to that. The point is about one point about verification. So we are very aware, and one of the things we raise with coders is that when pressure ulcers are verified, you quite often are saying that's not even a pressure ulcer, it's a moisture lesion, or you've coded it as a 3 and it's only a 2, or it's 2 and it's a 3. And we want to make sure that what gets pulled through into coding is the right information. So there is an option that if you work with your coding team, you can say to them that if this group of people, and you might list your TVN team or whoever you're saying are the people with the oversight, write something, then that's the definitive answer. So even if the ward staff have written it's a 4, if the TVN says it's a 2, it will get coded as a 2. So, you know, that's part of the information. I think the other part of the question was why couldn't we use incident data as well? I think, was that what, am I understanding that correctly?
I think so, yeah.
Because it doesn't pull through, because it's in a completely separate data system that you have to input information to. And this is what Heidi was saying about this point of care system. Clinicians are writing in the patient record, in the clinical notes all the time, every day. And we want to be able to access information that is part of what they are doing, not part of an additional task that they have to do. We do know in some organisations, so one of the pilot sites we work with have employed a team member whose role specifically is around verification of pressure ulcers. So they look at the incident system, they go around and they verify everything, and they put together a table and chart, and they go and sit with the coders and work through it with them. And they have to write it in the notes because coders can only take from the notes, but they go and verify everything. Equally, the coders, once they start to know the team, if they've got something they're not sure of, we know that they will ring you. So if you tell them who's the link for that, then they will. Anything you want to add to that, Heidi?
No, I don't think so. I think that covers that. Yeah. I'm just going to answer one of the questions because I can answer it on the chat. So there is another question about when does the sequence start?
Sequence starts in April, but you obviously can't pull the data until end of June because you report after the first quarter.
Just answering this one.
And it is a fairly straightforward process. It's about risk assessment. And if you think we've had the nice guidance on risk assessment since the guidelines in 2014 and the statements, the standard statements on do it within 6 hours or on first visit since 2015. So that's, 7, 8 years on, depending on which line you take, we really should be doing this. So we should be quite good at it, and I'm hoping that we will have quite good achievement.
Somebody said it was Teresa Mitchell that has her hand up. So I don't know if you can come off mute, Teresa, and ask your question.
I did have my hand up, Heidi, thank you, but Jackie answered the question that I was going to ask about the consultation paper.
Okay.
You're waiting for it to be aligned to the pathway, so that's absolutely fine. And the only other thing that I was going to say is that I think that it's going to be a little bit confusing for staff around the new terminology with the DTIs and the unstageables, because if we use the word deep tissue injury, we're automatically thinking that that's going to be full thickness skin loss, in which case at the moment nurses will report a DTI and they will say a minimum Cat 3. Whereas now we're saying that the unstageables are going to be a minimum Cat 3 and the DTIs, if I'm correct, will be recorded, but we won't actually decide what they're going to be until they've evolved after 72 hours. Is that correct?
I mean, if it's a deep tissue injury, as you say, it is a minimum of Category 3, but we know from lots of reports that not all deep tissue injuries become deep tissue injuries. Many of them do resolve. So we know lots of clinicians spending time pulling back incident reports, changing incident reports so this wasn't a DTI, and we're trying to get away from that. You know, we're trying to save some time for people. It's not saying to staff, don't acknowledge that there's a potential deep tissue injury. It's not saying, oh, you don't have to worry about that anymore. It's about what you write and what you record. So, you know, if you want to record it as a minimum DTI minimum Category 3 and know that you're going to have to change that, then, you know, that's your workload, that's your choice. We're saying, why not wait and see what it is? And we take the point somebody put that sometimes they take more than 72 hours. A true DTI, you'll start to see a breakdown in the skin within around 72 hours. It'll be a small number that don't break down. And the reason I keep saying a small number is if you think about that workload, if you do them all, that's a lot of things to change. If it's one that you need to change, you know, one a month or one every 6 months, that's a lot less workload to go and have to rechange it. And Claire, you've asked for why is a DTI a minimal Category 3? Because if it's a deep tissue injury, then it's not skin, it's tissue, deep tissue. So it has to be a Category 3. So if what you are seeing is something that becomes a blister, actually it's not a deep tissue injury in the first place.
Somebody's got their hand up. I'm just going to put Gillian Harmon's question out to you, Jackie. Will there be plans to produce an e-learning module for children's services? They get a lot of requests for that.
What would you want to be different in that module, Gillian, that's different from adult services? Obviously, you know, we know that there are lots of differences around patients. What we tried to avoid doing is doing too many separate modules, because we could also do one for mental health, one for learning disabilities, one for end of life care, one for hospice care. You know, that there are lots of things. We try to make our e-modules generic enough that you can put information around them so that they apply to your particular population. So if there's something you think that we're not doing with our pressure ulcer module to make it better and more applicable to paediatrics, we'd be really happy to do that, because it's due up for review. I think, is it one of the ones you're reviewing at the minute, Heidi? Pressure ulcers. So,
yeah,
you know,
it's
a good time to tell us now something we can put in there to review. We're also really aware that, you know, there are quite a few groupings of specialist interest people. So I've got a group of critical care and tissue viability clinicians that hang over from kind of 2018, where we had a working group to develop all that device related work, and I maintain those as an email group. We're looking at putting together a group for neonatal practitioners, and a group for paediatric practitioners already exists, but hasn't met very much. So it might be that we need to start linking a bit more with those subspecialties that are close to each other, and finding out how we make things work better for you. And maternity would be in that. Deborah, you've put a query about maternity, because maternity are challenging me at the minute with this. Why do they have to be included in the sequin? Which I think they do.
Somebody's asked a question about what are we expecting in emergency department and ambulance in terms of the pathway that you showed, and regarding skin assessments and risk assessments?
So in ambulance and emergency departments, we would expect you to follow the pathway, and the pathway, the first steps would be screening. So if you're using Purpose T tool, it would be the screening, and within 2 questions and your clinical judgment, you can simply decide that that patient is not at risk of pressure ulcers, and all you need to do from that is record that decision and decide when a new assessment is due. And obviously, if the patient's condition changes, do a reassessment. Purpose T is much quicker than Waterloo. And in saying that, though, I know lots of you aren't there yet. So lots of organisations aren't using Purpose T. They're using Braden and Waterloo and other tools. So it's down to your local organisation about how they implement this. And I'm talking to an organisation at the minute about maternity who were about to change over to I've forgotten the name of the new maternity electronic patient record, and we're going to put an amended Waterloo in, but they're now thinking actually they'd be much better to move straight over to Purpose T and do 1 change rather than 2 changes. So we expect the pathway to apply to every element of the service. That includes ambulances, it includes emergency departments, includes discharge lounge. Everybody should be thinking about patients' risk of pressure ulcers.
So I'm going to answer Robert Gannon's question because he's popped in that he works at the Royal Papworth. Their hospital is payment by contact, not results. So coding don't engage as there's no impact on payment. So I guess the first question back to you, Robert, is what do they code and why? And then secondly, that their EPR has not got the capability to pick out the keywords if we did code. A lot of electronic patient record systems have got a coding system sat behind the words that we select. So it might be worth exploring how you can get information out of your EPR. A lot of them do. And I have said, if you want to contact me outside of this, I can show you a couple of pilot sites EPR systems and what they've done just using tick boxes and drop downs, for instance. And that's all linked to a way for them to be able to pull out the records. And sometimes, certainly in the community, if you're using something like System 1, which you're probably not in the hospital, but that's got codes sitting behind all the clinical information that we put in. Clinicians often don't even know that there's a coding thing attached to that, but we can then pull codes out on it. So it might be worth, if you want to explore it in more detail, get in touch and we can look at what your EPR system might or might not be able to do. I don't know, Jackie, if you're picking up on anything else in there. Somebody's a control freak about verification.
And that's fine. And Sarah's put that, and I've put a comment, Heidi, about our response from the coders has been incredibly positive, hasn't it? They've been so pleased that we've engaged with them, that we've taken the time to listen to what they're talking about and understand their language. And we really felt it was just complete gobbledygook when we first engaged with them. We went round and round in circles, but we think we've got it at a point where we can explain it to you guys simply enough that you can go to them and sound like you know what you're talking about a little bit, so that they know what to talk to you about. You know, and if any of you are still keen to do that, Heidi didn't mention she's done a really good how-to resource on engaging with the model health system, and that's going to be up on the website shortly. It's just with our comms team for corporate branding type things, and that will be there. But we are very happy if you want to have a call with us to support you in those first conversations with your coding teams. Tell them about the work we've done, why we've done it, and where we're at to help you have that first level of engagement.
Oh, Jackie, I've seen another question. Deborah's asked if the slides will be shared afterwards.
The website's going to be shared. Webinar's going to be posted on the website, isn't it, Francis?
It is. Yeah. Can the slides be shared as well, or?
We wouldn't usually share our slides, would we? We can share them. I mean,
no, we haven't previously.
Yeah.
I don't think there's any more questions. I think you've answered some of those that were asked.
Yeah, so if there's anybody who just think of a question, you know, sometimes it's something that you need to go away and think about, or maybe talk to your team about. You've got our contact details on that last slide, or you can just go to the National Wound Care Strategy website and contact us from there, and we'll be happy to answer any questions that you've got.
Actually, I have found one from Krista. What work is ongoing to identify novel treatments to support early intervention in the community to mitigate hospital admission? Don't know if she's talking about the SEM scanner there or something else.
Yeah, I'm not quite sure what the question's about. Do you want to come off mute and just tell us a little bit about why you're asking the question? What is it you're looking for in terms of a response? Who was it again, Heidi?
Krista Dyson.
Are you still there, Krista? Can you hear us? As you know, within the National Wound Care Strategy, we don't generally recommend any particular types of treatments or interventions. We follow what the evidence says. So where there is evidence for interventions, we will, of course, support that. And in the care bundle, we will be basing it on the evidence that we know we have.
When are the bundle and pathway to be available? I think we've got to go through the consultation first, haven't we, Jackie?
Yeah. So, Karen, the recommendations and the pathway will go out for consultation first, and then we're putting together the bundle in the background. We have to have a semblance of a bundle ready for May, for when Chief Nurse launches her new strategy. She wants to include elements of what will be produced in there, but we're working towards the end of Q2 to have the full bundle ready. And I think that brings us to the end of the webinar. So thank you all very much for your time and attending.